moderating factors, position, breathing, coughing, are there things that either make the pain better or worse that can give you a clue as to the source of the pain and the character of the pain, particularly when it refers to abdominal pain. Okay, abdominal pain that's worse with coughing, especially if it's localized, makes you think maybe appendicitis. Chest pain that's worse with inspiration is pleuritic pain. Gives you a sense that maybe this is either a pulmonary embolus, maybe it's pericarditis. If there's fever, it could be pneumonia with pleurisy. So again, relieving and exacerbating factors. And then the modifying factors, things that might alter the person's perception of pain, pain threshold, namely drugs, alcohol, and what other medications, analgesics that they may be on. So all these things you have to take into account. All right, so in treating it, okay, before we jump into the med box, treating the pain, a lot of it is, again, doing a very adequate, thorough, but not overly extensive assessment to find out if you can identify the source and the cause. Because if you can determine that, your means of treating your modality is going to be affected. Obviously, if somebody's having ischemic chest pain, you don't necessarily have to give them morphine, you give them nitroglycerin. Okay? It's not a pain reliever per se, but it's going to relieve their chest pain by relieving your angina. So treat the source of the cause if possible. Assess the vital signs and the effect with analgesics. Again, what you're looking for is a reduction in their heart rate, reduction in their blood pressure, reduction in their respiratory rate, things that tell you that things are going in the right direction. Very important to obtain a medication list, current analgesics and the doses that they're taking, because again, people who are on opiates are going to have a higher pain threshold. They're going to need probably the higher end of doses that you might otherwise expect. And then allergies. A lot of people have allergies to opiates. I'm allergic to codeine. Okay, well not all opiates are alike. People can be allergic to codeine, but not allergic to hydrocodone or oxycodone or morphine. Or they may be allergic to all opiates. You won't often know that. And allergy may not necessarily be true allergy. Most people who say they're allergic to codeine, they're actually gives them an upset stomach. It causes abdominal cramping, they feel sick. It's not an allergy, but they're perceiving it, or they've been told that they can't take it, which means, in other words, that they're allergic to it. It's not really an allergy. And a lot of other opiates actually are not as upsetting to the GI tract as codeine. So establish IV or IO access whenever possible. And that's because the effect of the medications that we're going to be administering are potentially going to have a profound effect on vital signs. So if you don't have some sort of IV access, you can give these drugs intramuscularly, you can give them intranasally, you can give them through the endotracheal. And that's all well and good, but if you don't have an IV in place, once that patient becomes hypotensive, obviously you're behind the eight ball. This happened to us the other day. We had a lady who came in with a hip dislocation, terrible pain. She got some fentanyl en route. Anybody remember that nice elderly lady? Hip dislocation, terrible pain. Got some relief from the fentanyl. Came in, had breakthrough pain. So obviously we want to get her relaxed, get her pain-free before we try to reduce her. And in our hurry and our ambition to try to make her comfortable, the nurse gives her morphine, which is ordered by the provider, 4 milligrams. That's a reasonable dose. It's a good pre-procedural dose. Unfortunately, the patient at that time wasn't on the heart monitor, and she didn't have a pulse ox on. So she went down very quickly. She soaked up that morphine, and next thing you know, she's out. Okay. And she's hardly breathing. She's breathing, and she's got a perfusion pulse. Quickly put her up on the monitor. And what do? I mean, does this happen in the field?
Yep.
It doesn't have to be 4 milligrams. It could be 1 or 2. People who are opiate naive are going to have, you never know what their response is going to be. So what do we do?
Oxygen, maybe a fluid challenge to raise the blood pressure.
Right, okay. Basic things, right? What did we do to try to reverse it? We try to reverse it?
Well, you don't want to try and reverse it because then you're chasing your own tail.
Right, okay.
You can start pulling on her leg then.
Reduce
So we tried to reduce that.
That's
Yeah.
what we did. That's what we did.
Go, Adam.
Pam looked at me, I looked at her, she said, why don't we do this to the hip? And I looked at her and said, well, he's not breathing too well. I said, I think you're right. Next thing you know, she's turning up on the head, going on the head, and she's loosey-goosey, and she yells out a little yelp. Boom, she's back in. And we did give her a little bit of Narcan. And we'll talk about reversal a little bit later, and how you can do it without creating acute withdrawal. All right, and then of course, medical control. And then, as you know, there are standing orders that folks can give opiates, depending on your level, your EMTPs and your EMTCs, for giving that first initial standard dose of opiates, and then notifying medical control. Okay, drugs of choice, the 1 to 3 scale, mild to moderate pain. Obviously, if the patient can swallow, start with the basics, keep it simple. Acetaminophen, Tylenol, why that, and not Motrin or Advil or ibuprofen? You guys carry ibuprofen?
No.
Advil? You carry Tylenol?
Yes.
Why
But no
not
water.
Advil?
Yeah, no water, yeah. No water. Just
No rectal, rectal only?
No, we have PO, but we don't
You
have
have
any
no
water
water.
for them to drink it.
Yeah, you don't have anything to drink it with?
Right.
Okay,
Well, we have antacid.
there you go.
Chug it out.
Chug it, so, okay. So why not the non-steroidals, why not the,
Perfect.
Bleeding?
yeah, bleeding, more side effects, more potential complications, more people, if you don't know if they might have allergies to NSAIDs or aspirin products, and the bleeding risk is greater. So again, use the thing that will have the least potential. People can be allergic to Tylenol. Have you ever heard of that? People having allergic reactions to Tylenol? Yeah, and it's not just a stomach ache. So, I mean, you can be allergic to anything. And it may not be the drug itself, it may be the binders that they use when they formulate the pills, the drug. All right, moderate to severe pain. Okay, this is where we get, beyond BLS and ALS certified folks can administer morphine sulfate. And the dose is usually 0.1 milligrams per kilogram. This can be given IV or IM. Can be given up to a total dose of 6 milligrams for adults and up to 4 milligrams for kids under 6 years of age or under 35 kilograms. How else can it be given? Any other routes for giving morphine sulfate? Have you given it any other way than IV or IM?
Thanks.
Intranasally? Not really, right? How about through aerosol? Has anybody given it that way? We'll do that sometimes in the hospital, and actually can be very effective for patients with, who are particularly anxious, who have respiratory distress, cancer patients. So it can be nebulized. Morphine can be given that way. Again, it won't be given in your setting, but we'll use it that way sometimes when we arrive. Moderate to severe pain, that's 7 to 10 range. Now we're getting into more potent opiates, which is at the level of an EMTP, which is fentanyl, 0.5 milligrams per kg, IV, IM, or intranasally. You guys give this intranasally ever?
Yeah.
You give it through the regular ampules? You just draw it up into, how do you atomize it? How do you aerosolize
We
it?
have atomizers on the truck.
Right, okay, so you'll just put
Drawer
it in
into
the
the
atomizer
atomizer
ring.
syringe.
And how often do you do that? Does that come up very often?
No, but it's
That's
good
good.
for pediatric patients that it's difficult to get IV.
Right, exactly. And then actually, we do that in the ER too, when we try to do conscious sedation in kids. Giving them intranasal fentanyl is a nice way to do procedures. They need to have a quick reduction of it. But it gets everybody a little nervous, because they don't have IV access. And then the dosage here, it doesn't sound like, big doses, but I'll show you the conversion chart in a little bit to show you what the dosage equivalents are amongst opiates between morphine and fentanyl, and the other one is hydromorphone. You guys don't give hydromorphone undilauded in the field, right? It's usually either morphine or fentanyl. Why not hydromorphone? Why not dilaudid? Hmm? Right, it's very potent. It's actually less potent than fentanyl, but it has a longer half-life. Fentanyl is fairly short-acting, so if something happens, typically you'll be able to get the patient through it, support them before they come in. And then if you do get into trouble, naloxone or Narcan. And again, this is the 1/10 of the dose that would be used for reversal. So if you've got somebody who is completely out of it and needs to be reversed, it's 0.1 milligrams per kilogram. Up to 10 milligrams is a reversing dose. And we know in this day and age with the high, fentanyl grade heroin that's out there, that 0.4 milligrams, forget about it. That's what they forget about it. Not gonna work. 2 milligrams may not be enough. You're really surprised at how much you have to give. And again, IM, IV, or intranasally.
Dr. Van Eyck,
Yo, question?
do you have a personal preference, morphine over fentanyl, and if so, why?
Okay, good question. If patient, for pain control, it's optional. It's completely equal in my mind. We're more used to giving morphine in the hospital setting, so we tend to be more comfortable administering that. But we give fentanyl as well. The thing with fentanyl is that the potency is so much greater. And, but the advantages of morphine are in patients who are cardiac patients. If you believe that they may be in congestive heart failure or pulmonary edema, there's a preference for using morphine in that setting. If it's just pain from trauma, from an obvious fracture in somebody who's young and healthy, and there's no cardiac issues, then fentanyl is fine. Answer the questions?
Yes, thank you.
Yeah. Okay, so here's one of the important things, opioid analgesics. Come to think about this, so when I'm giving morphine, what's the equivalent dose of that in terms of fentanyl or hydromorphone? Again, hydromorphone is dilaudid. But the ratio between fentanyl and morphine is it's a 100-fold difference. Okay. So 0.1 milligrams, okay, or 100 micrograms of fentanyl is equal to 10 milligrams of morphine. So what's the maximum dose of fentanyl we give in the field?
50 for adults.
50 micrograms. Okay. That's equivalent to 5 milligrams of morphine, roughly. Okay, so there's no oral equivalent for fentanyl. But that's a useful thing to know, that you're dealing not with a 10-fold difference, it's a 100-fold difference in terms of opiate potency. So for people who are opiate tolerant, who are already on some morphine or OxyContin, fentanyl's a good choice. Okay.
Why is that?
Because of its higher potency.
Just because they're used to that?
Right. And they may have more of a tolerance for morphine per se. It's a slightly different opiate, but again, you're getting more bang for the buck.
Okay, what do you expect the half-life for IV morphine versus the IV fentanyl?
For IV morphine, the half-life is going to be about 2 to 3 hours. Okay. Now, that doesn't mean that the patient won't continue to have pain or that the pain may not be getting worse, but you got to remember that when you're giving more morphine, within that 2 to 3 hour interval, the effect is going to be cumulative, the side effect profile.